Hello, everyone. Welcome to another CPS Solvers inviting residency programs. Today, we have the pleasure to receive Sinai Baltimore Internal Medicine Program. This is their year number 4, presenting a case. Us from the CPS Solvers, we are huge fans of them, and we have a lot of our members that are residents and a PD in the program. So for us, it's a pleasure to have you all here. And I will pass the mic for them to introduce themselves. It's probably faces that we already know, but they can say hello. Yes, do you want to start it?
Me, yes? Okay. So, hi everyone. This is a little bit surprising for me because now I'm not only CP Solvers Jazz, now I'm like also from Sinai. So I'm very happy to see you all here, and hopefully you can also share with us all your thoughts about the case that Franco is presenting today on the chat. And yeah, let's have a nice time. Next, I think is Dr. Yes. Would you like to also introduce yourself?
Yeah, thanks, Yaz. I think the challenge for today is to find out who's discussing. Is it Jazz or Yaz? And we're gonna probably have to clarify a couple of times before we speak. But yeah, my name is Jazz. I'm a hospice here in Rochester, New York. Been part of the CP Solvers, I think, for a very long time now. I'm excited to discuss this case along with Yaz, and I think we have a pretty excited case from Franco. So I'll give it to Franco for him to say hello.
Hi everybody. I'm Franco. I'm actually graduated from Sinai. So right now I'm doing my fellowship in University of Washington in Seattle. Um, so yeah, Sinai is a great program. Happy to be here. Happy to discuss a case. I know that everybody's gonna do right on the case, and it's a really exciting case and a learning curve also. Yeah, just to let you know that from the Sinai perspective, the program is excellent. It's amazing, get you to the places where you want to be in a friendly environment. So yeah, basically that's the my 2 cents on Sinai. Yeah, it's a big family. Should I pass the mic to somebody else? Jeff or Jeff?
Yes, who's scribing for today?
I'm scrubbing today, so I'm Julia
Awesome,
from
Jill.
Brazil. Excited to see Franco's case and this discussion.
We have another members from the program. Ravi, do you want to say hi?
Hi, hope everybody is well and excited for Franco, who I deeply miss, who has gone to the other side of the country and has been a stellar, actually, probably the first CPS member to join the program and has been outstanding. And he's been a trailblazer. So, really excited to see what he's brought with this case today from Seattle. So, back to you, Deborah.
I'm just gonna let the opportunity for Dia and Johan to say hi too. They are from the program.
So, hi everyone, I'm Johan. I'm first year resident at Sinai. And I remember last year I was just like you watching this VMR. And I remember Franco introduced the program really well. At the end of the session, he shared his experience and talk about his first contact with the program and how he was able to grow in the program. And he really helped me to, rank the program and really know that I want to be in that program. So I'm really excited to see Franco discuss again today. So thank you all and I hope you had a great Thanksgiving week.
Yeah, and hi, I'm Gia, the second year resident and also CP Solvers and also a member of Sinai. I'm very happy to be back to the live CP Solvers sessions and see so many friends' face and really love to hear the case and very excited for that.
Okay, I think we can start with the case.
And Yaz, do you want to take the first aliquot first?
Got it. I can do that.
So,
Perfect. Okay. So this is the chief complaint is general malaise, bilateral shoulder pain for 1 year. A little bit of the HPI, So this is a 62-year-old male with prior medical history of nephrolithiasis, type 2 diabetes mellitus, hypothyroidism, who initially had this 1 year of initially progressive fatigue. That was, according to him, he was able to perform his ADLs in a diminished range from month to month, to the point that he was not being able to actually walk probably 2 blocks without getting winded, or sustain amount of like her bilateral upper extremities above his headline for like more than 2 minutes. Um, yeah, and I think I can work. I can stop there.
Okay, so I'm tackling this first. So just to be completely transparent with you guys, it feels very different to be like discussing this as an intern from this program. But yeah, now talking about malaise or fatigue, I think it's a very broad thing to start with. Normally, we can first exclude any type of like lifestyle issues. This is a male, so normally I will think, okay, are there any other things accompanying this? If they have something related like uh, malaise and fever, or malaise and shortness of breath, malaise and something else. Because first things first is to determine if there is any organic etiology, like something endocrine going on, something hematologic going on, something infectious going on. Now, how can we discern that? I think that the onset is one of the main things we can look at. This person has been going on with 1 year of progressive fatigue. So honestly, as much as I love ID, I wouldn't put infections in my first place. I would think something more endocrine, something metabolic, something even look for exposure, something toxic. I remember that in Jas here presented us like it was a cadmium toxicity was one of like very weird heavy metal disease, cobalt, sorry. So think about those kinds of things before just throwing here what the diagnosis could be. Try to discern what is the onset and the probability of what else can we start. And another thing that I also wanted to talk about was this difficulty to walk more than 2 blocks to fatigue. I would also ask the patient, like, is this like, how does it feel, the fatigue? Like, is it shortness of breath, or like your whole body feels heavy, or is it painful? I think that's one of the things that I would start talking about. What do you think, Jess?
Yeah, it's nice to see how much you've grown since when you were a CP solvers. Now you're basically, into residency and discussed it flawlessly. I don't have a lot to add. I just want to recap the things that you highlighted yourself. So I think time course is key here. It's been 1 year of progressive fatigue. Fatigue is very non-specific. And Deborah, I didn't mean when you were a CP solver. She still is a CP solver. You know what I meant. Deborah just hating on me. So, I think the fatigue here is key. It's like, how can we apply fatigue, which is a vague, non-specific symptom, to this patient? So this patient has nephrolithiasis, hypothyroidism, and diabetes. And you astutely said that endocrinopathies can do this. And both hypo and hyperthyroidism can lead to myopathies. And that could be leading to the fatigue this patient is having. I think the biggest thing that took me it took me a little bit of surprise was the fact that this was a relatively healthy 62-year-old gentleman that was able to do his ADLs and now can't walk 2 blocks. So that's a big change. And even though this has been going on for a year, I would argue that his progression is subacute, so maybe even probably not acute, but definitely subacute. So now this gets my antenna higher to make sure that we're not missing a systemic inflammatory process that is leading to perhaps not necessarily weakness where you actually have motor weakness, but maybe this generation of stiffness or asthenia that can explain a patient that is greater than, it may explain a syndrome that in a patient that may happen in older than 50. But to be honest with you, given his history, you have to get a simple TSH, maybe look into his med list to see if he has a statin. Has he recently gotten steroids? And I think before we go down the realm of like, autoimmune associated myositis, I just personally think we need more history. Because is it proximal? Is it distal? Is it both? And most importantly, is it even weakness? I think that's the next thing I would want to clarify in the next aliquot. But everything else you said was spot on. So I'll pass it over to you, Franco.
Perfect, great. I love how this is starting. Just to clarify, he couldn't move bilateral upper arms above the shoulder line, because of pain. So a little more of history there. He never reported dyspnea. He never reported chest pain. He just said, "I have extremely fatigue." Um, Prior medications for him, he was on metformin, levothyroxine, everything, stable doses, atorvastatin as well. A family history, none. Social history, he works in the Navy repairing ships, um, here in the Pacific Northwest. He did not travel extensively with the Navy, but he was around multiple ports within the US. No smoker, no drug, no alcohol, no allergies either. Um, Before giving the vitals, he actually went for these so-called self-pay MRIs because of this pain before going to any of the doctors. In his case, it shows something. So I'm just going to show that image right now just to give a little twist on the discussion. Let me. And this is the MRI that he got. They describe as innumerable bony lesions in large bones and also small bones through all the body. I'm gonna stop sharing right now. And I think I can stop there. Unless you want some clarifying questions about the history or anything that you need to know at this time.
I'm just curious. So this MRI was done by himself, like through private?
Yeah,
Like,
self-pay MRI, whole body.
Interesting.
Because
This,
he
I don't think.
couldn't stand anymore the malaise and the general pain that he had.
Gotcha. Yes. Do you want to flip flop or do you want to keep the standards? Like, are
You
you
can
going
start.
first?
I think I have to put in order all my thoughts because
Okay, that's fine.
what's going
All
on?
right. So, what a fascinating start now to this. What a twist, to be honest with you, in the second aliquot. So I think obviously the elephant in the room is the bony lesions. But before we go into there, I think it's good to know that this patient did not report dyspnea or chest pain. So his the fact that he wasn't able to walk 2 blocks probably moves away from the bucket of the chest cavity. So whether it's the lungs or the heart, but now it sheds light on blood and specifically anemia. Sure, he's on a torvastatin, but you have to ask him how long he's been on it. Does he have proximal muscle weakness? And it seems like in this gentleman, he only had upper extremity. Usually, you would expect, both upper and lower extremity. And I think if this patient is getting admitted to the hospital, I think I definitely would be holding the atorvastatin while we get more data. I think his social history is interesting when working in the Navy and repairing ships. I think Dr. Robbie put a great kind of schema for what you want to think there. But I think now focusing on the fact that this MRI showed innumerable bony lesions. In the first aliquot, I'll be honest with you, I was thinking of in a gentleman that's older than 50, a PMR PMR was polymyalgia would fit perfectly for this patient's presentation, especially not able to lift his arms above his head. But now with the innumerable bony lesions, PMR does not make sense. And I would be concerned about an underlying malignant process. Like especially, and I would want to clarify with the radiologist, are these diffuse lytic lesions or osteoblastic lesions? But to be honest with you, if you want to combine this with the anemia, I would honestly be concerned for either metastatic malignancy from a primary source of unknown or a multiple myeloma picture, especially given the age. of 62. But where can metastatic solid malignancy come from? Prostate, lung, thyroid. We know he has some thyroid issues. So I think the last one is a lymphoma with osseous involvement. And then I think with his endocrinopathy history, you also have to make sure, especially with the nephrolithiasis, right? Does he have like this occult hyperparathyroidism that's leading to hypocalcemia, which can hypercalcemic bone disease can lead to lytic lesions, especially if they lead to brown tumors. But I'm having a tough time attributing it to the innumerable lesions to just primary hyperparathyroidism. I think now the inflammatory myopathies or the PMR seems pushed away a little bit just because of the innumerable lesions that were found in the MRI. But yeah, I would love to see how you can like kind of recap or add any things to what I said.
Definitely. At this point, I think I can only recap because I agree with you. There are so many things going on right now. So we know that this patient had bilateral upper arm weakness. He couldn't move the shoulder line. So if you have told me that this was only one side, I would have thought, well, let's rule out adhesive capsulitis, rotator cuff tendonitis, stuff like that. If it's bilateral, I will think, okay, something systemic. And a lot of people pointed out like myositis. Like I really love the ideas. Then this difficulty walking more than 2 blocks, I'm also thinking, well, the pelvic girdle is also affected. So definitely something. My first reflex was to think something endocrine because he has this diabetes and has hypothyroidism. To think, okay, there's something metabolic or endocrinology going on. But then we have this new ingredient of this person working in the shipyard, and all IMGs and everybody here will not let me lie that whenever we hear shipyards, we're like, oh, the vignettes tells me like look for mesothelioma and look for acistosis, look for all these things. But before putting this patient in a box and thinking that this is solely something malignant, I will definitely want to know how are his levels. Like first of all, I think I already saw it in the chat, like thyroid panel, calcium levels, obviously a CBC. I see that he doesn't have any dyspnea or chest pain. So I'm thinking, well, maybe even if it was something like interstitial lung disease, something fibrotic, he would definitely have some issues with that. So I'm really wondering, like the first thing I would put a stat will be like all this metabolic panel to see how his levels are. But that's so far everything I could add to. But yeah, Franco, can you give us more information?
I was also on the same spot as both of you when he brought that MRI. And just to clarify, also, everything is happening in the outpatient world here. um, so vitals pretty much a febrile 37. It was. Let me just double check. 37 Celsius. Heart rate was 98. Blood pressure was 120/80, perfect blood pressure. Respiratory rate of 16. He was setting 98% on room air. BMI 26.
Mm-hmm.
General exam, he was thin, a little bit pale. Hand exam, no lymphadenopathy, no oral ulcers. Cardiovascular, no murmurs, normal rhythm rate as well. Pulmonary wise, no wheezing, no crackles, continued transmission bilaterally. Abdomen wise, non tender, soft, no mass. Neuro wise, at baseline, no focal signs. Extremities, he did have focal tenderness on bilateral AC joints, the upper shoulders, limited active range of motion about 90 degrees on bilateral shoulders. Also limited with passive motion as well. Lower extremities, strange in all the extremities were preserved. Yeah, and I think I can give you the first labs as well. So just gonna okay. Let me look for the CBC. Okay, white blood cell count 3.5K, hemoglobin 13.8, MCV 90, MCH 30. Normal on the differential on the CBC, relative lymphopenia of 0.72. The rest of the differential were within normal limits. All's BMP was a creatinine of 1.28 from a baseline of 0.8 3 months before this lab. And that was also 3 months before the presentation. BUN of 25, calcium level 9.9, phosphate 3.2, sodium, potassium within normal limits, glucose 113, uric acid 5.3, LDH 152, AST, ALT within normal limits. Same with the bilirubin. CRP 2.6, ESR 20, beta 2 microglobulin slightly elevated on 4.2. Yeah, I think I can stop there.
Franco, I just had one clarification. Did you mention an alphos? And I think I missed the platelets.
Oh, alphos was within normal limits as well, and platelets also within normal limits. The only thing on the CBC was the lymphopenia 0.72.
Okay, now it's my turn to tackle the aliquot. So again, transparency here. I completely glossed over the MRI in my past discussion. And okay, something that I learned how to say in the internship is like, this is part of my knowledge gap. I'm not sure. I'm not good interpreting MRI. I'm not sure if this could be a lytic or a plastic or a mixed pattern. I'm pretty sure that if I saw this image of the MRI, I would be like, this is what I think, but I will wait for the interpretation. So, so far, if this was lytic, I would definitely think, oh, maybe this is something thyroid going on. As many people have already very brilliantly brought up, like multiple myeloma. If it was blastic, well, look at the prostate, But now looking at his laboratories, I see that he has, first of all, low white blood cells. But what throws me away a little bit is that his platelets and his hemoglobin are normal. I see that there's a elevation on creatinine, even if his baseline is 0.8 and it's just slightly. I would like to know what is going on there, if this patient was dehydrated or is there something, a secondary process that is actually damaging the kidney. Any elevation, we have to figure out, like that's something that our nephrologist taught me. I see that his calcium is in a normal level as well. If I'm not wrong, I think I would try to get ionized calcium. I am a little bit confused here because I would have expected to see a little bit more stuff going on in the CBC to begin with, and see at least an abnormal alphos. The LDH is quite a bit elevated, if I'm not wrong. So in this point, I am not sure what to make out of this laboratories, Jazz. I need help.
I need help. Also, I love how you said that something you learned as a resident is something that, I'm like, this is part of my knowledge gap. Yaz, I'm here to tell you that you're going to be saying that for a large portion of your career, and I still say it on a daily basis. So, yeah, I think this might be one of my knowledge gaps. So I honestly thought his labs were very interesting in the sense that he's pale on exam but no anemia. So that tells me there's a disconnect there. The other thing that I noticed was no lymphadenopathy. He, other than some lymphopenia, his lab work isn't completely normal. The thing that struck me by the greatest surprise was the alk phos being normal. And inflammatory markers are essentially non-inflammatory. The ESR and the CRP are completely like normal. So this tells me that whatever this process is clearly not. And I would love to know what the ferritin is, because there are some inflammatory processes that that goes above my pay grade of explaining why, but that will lead to a hyperferritinemia, like for example Still's disease, but doesn't really impact the CRP and the ESR is tremendously, or there's a disconnect, or there's a disproportionate rise of ferritin. So I feel like that's the next thing I would want to check in this patient, even though they're not anemic per se. But I think I the second aliquot, we were like, okay, could this be multiple myeloma now, especially we saw that lesions. But I guess I'm not as convinced as I was in aliquot 2, because there's no anemia, there's no hypercalcemia. It would be atypical for advanced myeloma to present like this. Um, and ESR would be elevated in patients with myeloma. The interesting part about ALK phos is, for those who don't know, that typically multiple myeloma won't lead to an elevated ALK phos unless it leads to a pathological fracture. So normal ALK phos does not necessarily exclude myeloma, and this could be a case of smoldering myeloma. Um, but I find it hard to believe that he has all those lytic lesions and it's all attributed to smoldering myeloma. I guess it's possible. But the biggest takeaway from this aliquot is I'm still not going to order an SPAP, a free light chain ratio. And I still would be, and also honestly in this case, yes, I will be checking a PSA. His lab work screams non like inflammatory cascade, but I've seen metastatic prostate cancer present like this, where their labs are like pristine, but it's all metastatic prostate cancer, and it can take time for it to take effect on the overall body. But because this is so benign, meaning his labs are completely normal, I do wonder about like a benign bony process, an example like bone islands. Um, but again, those bone islands would lead to an elevated alk phos. So then that's where I take a step back and say, I don't know if this makes sense there. I also, yes, I don't know what you felt, but I honestly felt that the shoulder exam was very interesting. For my limited experience in sports medicine, is when you have both active and passive reduction in range of motion, that usually kind of suggests of adhesive capsulitis. And I would honestly would be checking this patient's A1C if he hasn't recently had one, to see if he has uncontrolled diabetes, because by far the most common cause of adhesive capsulitis is diabetes, especially when it presents bilaterally. So I think that was pretty interesting, but I don't know how I would connect a adhesive capsulitis or frozen shoulder to this guy's presentation. It could be a complete um, red herring and not connected to the overall case. Or there might be an underlying process that I'm not aware of, other than diabetes, that could lead to adhesive capsulitis. Or there's another thing that can lead to a passive range of motion that I'm not aware of. I think when I'm stuck, yes, what I like to do is I like to look at the past medical history, and I think, you know, given his history of endocrinopathies and like, you know, his nephrolithiasis history, I want to know how recurrent it is, especially in a 62-year-old gentleman. Was it a long time ago or was it recently? His calcium is normal 9.9, but this might be a gentleman where I actually would get your 24-hour urine calcium and see if this might be like chronic hypercalcemic bone disease, that may have led to like from a secondary like hyperparathyroidism. 9.9 is high normal, but that's just a snapshot in time, and I just want to see if there might be something we might be missing underneath. But I'm kind of stumped. Hopefully the next aliquot might help us out.
Before you continue, Dr.
Yeah.
Gus, I now that you mentioned something paraneoplastic, or also you brought the polymyalgia rheumatica, I was thinking, well, two things can be true at the same time. What if this is actually a paraneoplastic process? And again, I think there are many very brilliant people in the chat that since the beginning mentioned, hey, both bilateral shoulder weakness can make us think about myositis. So there are this condition like paraneoplastic polymyositis, or try to figure out if it's like, I think that the most difficult part here would be if it's something malignancy related, if it's something paraneoplastic, if it's something purely rheumatological. Again, I'm being biased because I know Franco is in rheumatology, but again, I see your face, Franco. So I feel that I might not be that lost. Um, so yeah, I think that aside from, now that you validated me thinking about asking for a serum protein, electrophoresis, PSA level, I think that we can also consider ask for creatine kinase and aldolase, just to differentiate from polymyalgia rheumatica versus polymyositis. So yeah, let's see what else Franco has for us. Or
Yeah, and I just want to no,
yeah.
I just want to say that like one of the greatest things is knowing Franco is rheumatology, but then he gives us a endocrinopathy case. We don't want to be falling into that like pothole, right? And I'm trying to be authentic here. Yeah, I think paraneoplastic is this esoteria where it's one of those things. There's three things in medicine: cytokines, TB, and paraneoplastic syndrome. You can say in any differential, and your attending can't say no to you. So yeah, I think that might be possible, but let's see. But I agree with you. Yeah, that definitely is a possibility. Franco, mic to you.
Got it. Perfect. Yeah, we were on the same page as both of you. And we are reaching to the point that the labs were kind of like discordant with the burden of the of the imaging on the MRI. So let's do SPEP and UPEP were within normal limits. No issues there. Also, immunoglobulins within normal limits as well. Let me see if we got a CK. CK was also within normal limits. Aldolase, yeah, we did not get the aldolase. The CK came back negative, and his muscle strength was fine. They did a PSA 0.74 within normal limits. They also did a carcinogenic antigen that was within normal limits. And at that time, we made the agreement that we need to get some more imaging to explore what's happening. So from another consultant, they got a nuclear medicine bone scan that showed no scintigraphic evidence of osteoblastic metastasis, no abnormal radiotracer uptake. We also got a CT chest, abdomen, and pelvis. And that CT chest, abdomen, and pelvis, let me get it here because it's an extended one. Okay. From the chest, small to mildly enlarged lymph nodes seen measuring up to 1.1 centimeter. The parenchyma without acute airspace disease or pulmonary nodules or masses. In the abdomen and pelvis, bilateral renal calculi again seen measuring up to 6.5, no hydronephrosis. They rate it as liver and spleen unremarkable, no lymphadenopathies. I think I can stop there unless any of you want another imaging.
I
Are you
think we
interested in
can.
any imaging before proceeding, or should I stop here?
I guess you can stop here, Frank. I guess like my next question is how many more aliquots until the
It's
final diagnosis?
gonna be two more, and that's it.
Two more and then the final?
Mm-hmm.
Okay. Yaz, what do you think? You want to stop here to discuss this
Yes,
briefly?
definitely. Very briefly. So, okay, so this is a bone scan, no scintigraphic evidence of osteoblastic activity. So I'm thinking that this is maybe sclerotic. And again, it's really throwing me off that there is no lymphadenopathy, because the first thing I would have thought, okay, yeah, we have nephrolithiasis, we have this lymphopenia, numerous bone lesions. This has to be something, smoldering myeloma, multiple myeloma, plasma cell dyscrasias. Yes, fine. And then SPEP, PEP, and all those things come normal. The PSA comes normal. Immunoglobulins come back normal. So the next thing I would think would be, okay, could this be anyways, a metastatic disease from an occult primary issue, even if we have a normal PSA, a normal carcinoembryonic antigen, just guiding this with the lytic bone lesions and the constitutional issues going on? Or could this be something like I remember in one of the VMRs, like very long ago, because I know that I haven't been joining, coming in with systemic mastocytosis that presents with like bone involvement, osteoporosis, fragility, but this patient hasn't had any fractures and he's still working, repairing ships. So, I mean, I don't think a person with these kinds of issues could be able to work or keep on doing his normal activities without any kind of trauma going on. Now, another thing would be, I think that I saw in the chat something like sarcoidosis because of the multifocal bone lesions and this systemic B symptoms that we're seeing, systemic symptoms, sorry. But again, I don't know what to do with these levels. Like they are not telling me a lot of things. So one, am I not looking for the right thing? Or two, is this something more insidious? What do you think, Dr. Jazz?
Yeah, I think sarcoidosis, anytime you have lymph nodes and then bone involvements, is always a great thought. So I think I would agree with that. I think the part that took me by surprise was the nuclear bone scan being completely normal despite the MRI showing those potential bone lesions. So in those moments when I'm like not expecting a result, I ask myself like, okay, what does the bone scan look for? And the bone scan, you inject a small amount of radioactive tracer and it goes to the bones where there is abnormal bone activity. So fractures, infections, malignancy, these are called hotspots and they'll light up like a Christmas tree. But if there's less activity in that bone compared to the hotspot, it'll come up as cold spots. So this makes me wonder if this is a benign polyostotic sclerosing bone dysplasia. And it's like, why I'm saying that is the bone scan is negative despite the MRI findings, which just goes to show you don't get private MRIs. Like even if it shows something, like I don't know if it's completely relevant here. Like this guy probably got like $1 million workup and it was nothing. I don't know if the shoulders are connected here. I'm getting the more and more information we're getting. I think the shoulder was likely from a complication of his diabetes and he has frozen shoulder. But the bone pain that he was getting possibly could be related to this. And last thing I'm going to share is just because a PSA is normal does not mean it rules out prostate cancer. Although I will say that there was no prostomegaly on the pelvis CT, so that rules it out. But just a side teaching point that that if you have a normal PSA but you have prostomegaly on CT scan, you can have differentiation of prostate adenocarcinoma into a neuroendocrine tumor, and the PSA is completely normal. So there's this rare, but those things can happen, and it can present like with lytic or like these lesions as well. Yes, what do you want me to repeat that again?
Probably something else to.
Yeah, so it just basically think of it as like a benign bony disease. I've only seen it once. I did the same thing where I did like $1 million workup and everything was normal. And it's basically like osteopoicoliosis. Um, I don't know how to spell that. I don't even know if I'm saying it right, but basically they're bony islands and they're like they're sclerosing bone dysplasia is in another way where basically the whole workup is normal, and these dysplasias don't really lead to significant bone turnover, which is why the bone scan can miss it. And they're not really hypercalcemic, and they're really not having like a significant elevation in alk phos. So I would want to. I think that's the next thing. I guess yes. Let me ask you this: what would you do next in this patient?
The first thing I thought was like, okay, I'm going to page rheumatology, but something that I would definitely ask is, even if we have a normal SPEP UPIT, could we also order a serum and urine light chain to exclude light chain only plasma cell disorders or maybe go into ask for a bone marrow biopsy? But again, I think that I'm being too invasive. So those are the only two things that could come to mind, if I'm being very honest with you.
Yeah, I think just for the sake of time, we'll give it back to Franco, but I agree with that. And the only thing I think is, are we overlooking histiocytic diseases? I don't think they present this way, but that's something on the back of my mind as well. Franco, we're excited for the next aliquot.
Great, perfect. Yeah. So at this point we were on the, and this is not gonna reveal the full diagnosis. This is gonna be a little bit of discussion after this. But tissue is the issue here, and they got a bone marrow biopsy from one of the sites on the iliac that was approachable. And the reading was foci of loose epithelioid non-necrotizing granuloma with associated collagen fibrosis. However, there was a comment on the bone marrow biopsy by the pathologist that says that there were a few multinucleated foreign body giant cells identified with foreign bodies material in the light microscopy, but only on the light microscopy. Yeah. And that's where I can let both of you discuss at this time.
Is it my turn first?
I actually don't know whose turn it is, but before one of us goes, Franco, do you mind what was it was foreign body? I missed that.
Few multinucleated foreign body giant cells identify with no foreign material in the light microscopy.
I think Yaz, it might be your turn.
Oh
But
my
I can
goodness.
go.
Okay, I won't steal your thunder and ask what Asia syndrome, like explain it. But if I saw something like multinucleated foreign bodies, the first thing I would be like, okay, after his exposure, could this be some like heavy metal exposure, from silica, from whatever things he could be like inhaling during his shipyard repairing stuff. The first thing I would have thought with a non-epithelioid granulomas and fibrosis, I'm thinking tuberculosis. I'm sorry, I'm trying not to be biased, I promise. The thing is that tuberculosis I don't remember the percentage, was quite high with infectious bone marrow granulomas. The extensive like onset might be like coherent with what we are looking at. This chronic presentation, malaise, multiple bone lesions, this elevated, not so elevated ESR, but I would think maybe this could be tuberculosis. He was in the Navy. He might have gone through a lot of places in his young times, and now something just triggered this like immune issue that reactivated tuberculosis. We don't like, maybe I'm stretching this too much, but that would be like the most common things being common, because I promise you I would have never thought Asia syndrome as a first thing. Like if you ask me what would I think it's like more common, I would say tuberculosis. Oh, and the next thing would be sarcoidosis, just because of this granulomatous bone inflammation. Again, thinking about this bone involvement and this chronic indolent course could put it on my radar as well. And what I'm not very sure is about taking in consideration histoplasmosis as well, or cocci, because of the multinucleated giant cells, specifically in histoplasmosis, that can represent like this is one of the main findings on pathology of this fungi. But then again, I feel that I'm being very biased. Now, can you please talk about Asia syndrome, please?
So, that was great. Yeah, it's funny enough. I actually wrote a case report on Asia syndrome, so I actually I know somewhat about it. It's like it's so the full name for it is like autoimmune inflammatory syndrome induced by adjuvants, and these adjuvants is a non-specific term. But in our case, it was actually from the COVID vaccine. Not to stir controversy, but but yeah, it can happen to anything. Oh wow, Lyra, that was very fast of you. So it can be induced by a lot of different things, and adjuvants, like I said, is a non-specific thing. In this patient, first of all, I don't even know if this is Asia because I'll be honest with you, Asia usually has elevated inflammatory markers, and um, you know, I don't see that picture here. And the patient that we had in our case report had an ESR that was very elevated. So I'm not convinced that this is Asia to be very honest here. But I do think we have a sarcoid or a granulomatous type of reaction creating this type of situation. And honestly, social history tells us that this patient used to work on ships. And I don't know about silica because I would have imagined he would have had some lung involvement. I'm more concerned for beryllium, and can beryllium lead to um, this type of manifestation where he's having a non-caseating granuloma in his bones that's leading to isolated inflammation, but not systemic inflammation. But I'm not very sure. But I'm happy to learn. I know like sarcoidosis, TB, endemic mycosis can all lead to these type of granulomas. But I will say, I think that's definitely Robbie who's posting that in the chat. But I would say that this patient does not present in a way that makes me feel like this is a strong indolent infection. I think with the history of his hip repairing job, and now with this bone marrow biopsy finding, I am concerned of beryllium induced granulomatous change. But I'm so excited to learn from Franco because I'm making a guess here, but I'm not very confident. Yeah.
Great. We both of you are kind of like on the spot on pathway as we kind of like were also considering berylliosis as a potential diagnosis. A sarcoid was also a potential diagnosis, but the thing that was throwing us off is that there were no signal outside the bone. So when you usually have like either berylliosis or sarcoidosis, like isolated bone sarcoidosis without any other organ involvement is extremely rare. Same with berylliosis, isolated bone structure without any lung involvement for beryllium. It's also extremely rare, but we did have these granulomas. Um, all the infectious workup was also sent. There was no hint of a mycobacteria in his body with all the PCR from the tissue and also the serum. And at that time, we were saying, okay, let's see if these granulomas are functionally active. So his ACE levels were elevated in 91. His vitamin D 125 was also elevated, 82. He was also elevated urine calcium excretion above the normal. So we had like two signals there, like granulomatous disease on the bone and also a probable potential involvement of the kidneys. We ended up deciding to go for a PET CT just to see because we did not believe that there was nothing on that CT abdomen and pelvis. We wanted to make sure that there was any other organ involvement. And the PET CT did show marked FDG uptake in multiple lymph nodes in the lower neck, thorax, abdomen, pelvis, and splenomegaly, as well as FDG uptake in the axial and appendicular skeleton. So with that construct of having FDG uptake with multiple organ involvement, spleen, lymph nodes, and bone, and the concern of excretion from the calcium, we made the construct of sarcoidosis as that would be a common scenario for this patient now that we have the other organs involved and the non-caseating granulomas with the exclusion of the infectious disorders and also exclusion of malignancy. Berylliosis was basically ruled out because he had there was no chest involvement, and he was actually never exposed to beryllium. And we tried to get a beryllium steam test, but apparently it's kind of like not easily rateable currently. Um, so yeah, I placed it on prednisone, and we got a repeat PET CT like I don't know a couple of weeks ago, and all everything melted away, and he's doing great. It was just plain old sarcoidosis with renal involvement with the nephrolithiasis and lymph node involvement, and organ involvement, and bone involvement. He's using methotrexate as a steroid-sparing agent at this time. I'm gonna see him on Monday. So yeah, he's doing great. Just all sarcoid.
I just want to say that was like an amazing case, and sarcoidosis is another one like TB that can literally do anything it wants. Franco, that was masterly presented and learned so much. Yaz, your thoughts?
I am in good Dr. Ravi's fashion. I'm flabbergasted. I was thinking so many things. We were talking about Asia syndrome, osteoporosis, and we were like, I was bringing here all the bugs available, and it's sarcoidosis. So never get biased.
And also, just to clarify, the foreign body were the foreign body cells. So that is just an old number for having a multi-giant macrophage there that usually resembles that way. And they it depends the pathology that read it, they can call it like multi-foreign body cells in response to a composite granuloma. But yeah, it was a good learning case for me as well, especially because isolated bone sarcoid is extremely rare. I usually go with other organ involvement, so that's why we pursue that pathway.
Yeah, definitely. Like being the lung so clear, I mean, thank you so much, Franco. Definitely. So Dev, back at you.
Amazing. Great case, Franco. Thank you so much, Yasmin and Jasdeep, for for discussing, and it was amazing journey. So yeah, we have like a couple minutes for some questions about the program. If anyone have any question, please put in the chat. Maybe as we have Franco, Yasmin talking about the case, maybe if Gia wanna share a little bit about the program, how has been for her.
Yeah, of course. I'm very happy to share my experience at Sinai. I think during my first year and the half second year so far, I feel I'm like a work and learn in a very supportive environment. And even the initial first year, the whole like new system is very challenging to me, but I'm very feel very fortunate and blessed to have all the people or of my colleague, of my mentors that are very understanding and encourage me to learn. So I'm very happy to see my own progression, my own like growth in my residency training. And so I think such loving and supportive environment is what I like best for my program. And definitely, I think my program have a very strong training. So have been off the CP solvers lives for a while, and today when I re-enjoy the sessions and then think how I was in the CP solvers before, I can see how my thinking way, the way I'm think, the way I learn from the case is so much different. Yeah, so I'm very happy to share my experience, and I'm looking forward to see some of the new faces the next year.
Thank you. You seem really enthusiastic about the program. Johan, do you want to share a little bit? How has been your schedule?
Absolutely. I mean, first I want to thank Gia because fun story, during my first rotation at Sinai of residency, because I'm a first year, Gia was my senior. I was in the ICU and she was such an amazing senior. And I have so many great memories of that rotation. Well, with that said, to answer your question, Deborah, in terms of schedule, so I mean, we have all the normal rotation, but we don't have a 4+2 schedule. So clinics. We have clinics day afternoons most of the time. I mean, where we'll have a shorter day and then you'll go to clinic. So that's pretty fun because you can be in clinic more often and kind of every week, I would say. And at the same time, in terms of support, so we have um, good mentorship depending of your specialty of interest, peer mentorship as well with maybe a PGY2 or PGY3 who is doing the same. And overall, a part of that, I've contacted, for example, I'm interested in cardiology, and I've contacted recent graduate like Franco Aravin, and they're really, really keen to support as well. And I'm saying that to sh also share our culture at Sinai, and the residents are really supportive, regardless of if they're still in the program or not. And the overall vibe of the program is really friendly. Dr. Ravi as well is really supportive, and the leadership is really supportive, and they will push you in whatever you're trying to achieve. So um, I'm really happy to be at Sinai. That's my bottom line. Thank you.
Thank you for sharing. Yes, that was a question for you. What is your favorite thing about the program?
Honestly, I think that Gia and Johan had said like a big chunk of what our program is. Everybody's very friendly, from the staff in the lobby, the coordinators. But sometimes I'm thinking, how can they do so many things? They're amazing. Leadership, not only the attendings and our chief residents, they are always like very attentive to what we need. If they are also they really worry about having us comfortable, like learning in a good environment. So as Johan mentioned, they already gave us our mentor, can be attending like um, according to your what you want to do. For example, I've got a mentor and ID and attending, and I also had a peer mentor. So, and the nice thing about being a peer mentorship is that it's not unilateral. Like we both can support each other. Of course, being an intern, there's not much I can do, but they always make you feel like even if you're an intern, you are a good part, you're an important part of the team. And all of my seniors, this is not because it's being recorded, like even if I'm like struggling with the same order, they have a lot of patience. Like I've never met anybody inside of my program being like, oh, okay, intern, how can you not do this? Like they are very, very, very supportive, and they're always trying to teach you. So, and again, even if during rounds you say, I don't really know, like they ask you something, not about the patients, of course, because that's our responsibility, but about like anything like physiology or something like that, and you say, well, I don't really know, they take their time to teach you. So that's something that I really appreciate. I think I ramble a lot, so maybe who can, I don't see somebody else from the program. Oh, and by the way, Jazz, yes, we have ice cream. They give us these coupons to eat every single day, and you can use them for ice cream.
Amazing, yes. Thank you so much for sharing. I don't know if Julia, do you have a question to help us with the scribing, or just tip?
I think what's important in any residency program is residents trying to find time within or outside of the residency program to meet up. So I guess my question to one of the residents here is like, what kind of things do you guys do in Baltimore when you guys are not working? I think that really brings good collegiality into the group.
Well, that's a good question. So we have a lot of sports group. First, there is soccer championship in Baltimore, and we participate in that championship. So we'll train once a week. We'll have soccer games with the team. I mean, with the residents. We also have a pickleball group, for example, and we're pretty active in sport mainly. Now we try a restaurant here and there, try to celebrate birthday as well. So, well, we're busy, but we're trying to stay active and stay healthy. Yeah, Dr. Ravi is a really, really good soccer player. He's an active member of the team, and we're looking forward to have more players next year and do better in the championship.
Definitely. And for the people who do not play soccer like myself, you can also go there and support your team. It's very fun. Like the residency also like tries to cultivate that a spirit of like of getting together. They also do this social like end of block activities. We go to a farm, like the like this. I don't. Sorry, my English right now. I don't remember how you call them, but it's like little like pumpkin patches and stuff like that together. So yeah, I've seen that many of our resident members they get together to play pickleball and stuff. So it's really nice. Like the environment is really good. I think that coming as an intern sometimes is like, oh, I don't know stuff, and they will like not really pay attention to me, but it's completely the opposite in this program. And SteamLab, I've only had it twice. It's really good. We have a really good honest I was so impressed because again, I'd never been in one before. Dr. Ravi here, he's always like guiding you and he puts this like very real life type of thing. Like I won't give more information about what type of cases he gives us because I don't want to bias you guys. But he's very detail oriented in the way that he goes in the sim lab, and it helped me a lot. At least for me, when I went to ICU, many of the rapid responses I would be like, okay, I've seen this before in a mannequin, not the same of course, but I don't feel that bad. So yeah, Franco.
Or Sinai, oof, it's an amazing place that you will find family, but also mentors. It's not malignant at all. Everybody is there to help you. You can pursue the endeavors that you want, and also prepare you for the next steps in your career and give you confidence for those next steps. Collegiality among everybody is super nice. The cafeteria, I tend to that. I value the cafeteria for Sinai because it was less costly and there was a salad bar as well. So that's an important thing. Our cafeterias are like more expensive, but they don't give you enough food as a resident. The protected schedules during the you have accurate amount of rest during nights and during like your on-call time. You're never more in the hospital more than 12 hours, which is nice. So you don't do like extensive on-call hours. Um, the ice cream, I didn't. The ice cream. I mean, yeah, ice cream is nice in Baltimore. I'm not a huge fan of the ice cream, but there's always also food in the ICUs that you can steal, and everybody's collegial in the ICU. There are some places in the ICU where you can get things. um, yeah, overall, yeah, I don't think anything at Sinai, everything is what it's supposed to be and prepares you to anything that you want to do. That's the more important thing, and then gives you enough support to do the things that you want to do.
They're also asking Franco like what about the elective outside the hospital? We can answer that, but I think Vinny wanted to know like the what your experience as a graduate from Sinai now and your fellowship.
Got it. I think I'm fully prepared to work as a graduate during my fellowship. I think that from all my batch, when I keep in talking to anybody of them, everybody's well prepared. Everybody's performing well. Everybody feels confident enough to do the things that they want to pursue as well. Um, I reach out to Ravi as he program director, but more as a friend that he can guide me and give me mentorship. So all these little steps from Sinai and the people as a graduate, it doesn't end when you finish Sinai. The people in Sinai is also there for you, and you make good friends. Yeah, I think those are the most important thing. You never disconnect from your residency program, and if you disconnect from your residency program after it, that tells a lot. But if there's somebody else that is able to pick up the phone to give you guidance, to pick up the phone to give you some support. That's the most important thing, and the preparedness. You're well prepared to pursue your endeavors.
Yeah, I just want to share my experience as well regarding away rotation. So I started residency 7 months ago, and I tried to talk to attendings and mentors because I'm interested in cardiology, for example. And right away, one of our cardiology attending, who is my mentor now, helped me find a rotation at Hopkins, for example. So we have a lot of mentors. We also have a lot of PG, second year residents and third year residents that put me in contact with places where they did your electives. So you have some, I mean, everyone wants to help you, basically. Another experience I want to share as well is when I moved to Baltimore. I mean, when I was furnishing my apartments, so many of my co-residents helped me move in, and it just tells how much people are. Our overall group vibe and how we're all trying to help each other.
I saw a question about the protected time for research. You can arrange a research elective at elective moments. You have the blocks are divided in 2 weeks. So except for floors and ICU that are 4 weeks, you have electives, which are you if you're interested, I don't know, nephrology or cardiology or pulm or anything, you contact the attendings and you rotate with them 2 weeks. During these 2 weeks, depending, of course, of the rotation, sometimes there are too many consults and the times are a little bit more intense. But for example, I'm in palliative, so the time of because I chose to go to palliative, but my schedule allows me to do like research or do more stuff. But yeah, we do have elective time, or even during any other elective. There are like, I think it's a very nice balance between intense rotations, and then you have your elective, and then you have again floors, and then ICU. So it's designed in a way that you don't really experience burnout. At least as an intern, I haven't. So that's something that now that you are here, whenever you get to be interns, guys, that is something that's very important to see, that your program has this balanced like schedules, so you can have time to recover, you know?
Thank you, Yas, for answering all the questions, and Gia for answering in the chat too. Let me see. Yeah, Eugene did a question. Eugene, do you want to ask your question?
Yeah, absolutely. So I just saw Gia answering that question, but I can ask it so that everybody else can benefit. So I was asking about quality improvement initiatives that are resident-led for your program.
Yeah, I can answer the question because I remember last year several of our seniors, they are running a patient care to bedside QI project, and they hold all these residence education sessions at a noon conference and did the pre and post survey for us, and that's a very amazing QI project that even won several prizes at the ACP Maryland chapter. And currently we also have several other QI projects running on how to some very basic but very educational projects, like how to read the EKG running by our chief Ram. And also last year we have a QI project about inpatient DVT events, DVT prophylaxis. That's also very interesting. And currently, we're also thinking of several other QI projects by me and several other of my friends who are thinking how to improve the rapid response, residence performance, such projects. So we team up with each other very frequently and to do some QI projects, trying to improve our trainings and our education experience here.
Thank you so much, Gia, for answering. I think we talk a little bit about everything. If everyone want to share a final tip or like a piece of advice for, Robbie.
Yeah, I just want to add another thing. I mean, there's so many great programs out there, but we have a unique thing at Sinai, and just a collaboration with CPS, we've been able to steer so many wonderful people to our program. So Franco is like a brother to me. He's so endearing, and over the 3 years, what I've really been happy to have done with him is to allow him to flourish and become a magnificent teacher. And I think teaching opportunities is something that we really do really hold dearly here. We have many opportunities to teach. We have, starting from medical students, we have a medical school that just opened up with George Washington University. We still have Hopkins students that rotate, and then a few here and there that will rotate from other schools, osteopathic schools. We give opportunities for people to come in. And so Franco was always, everybody that rotated with Franco was like, he's the best teacher. So he's become this wonderful teacher, and he's taking that over to Washington State and is now teaching there with rheumatology. And hopefully we'll come back to CPS and share all the wonderful cases and all the teaching that he can afford to bring with him. So I think, teaching, I think being a teacher and being able to practice teaching is very important as a learner. An intern that does well teaching will become a fantastic resident who will teach the next intern. A lot of what we do in medicine and a lot of what we do in residency is pay it forward, right? So like Johan talked about residents helping, Gia has talked about, Yaz has talked about, and Franco, right? They've talked about residents helping them. So what you do as you grow up, you turn around and you help the other people that are coming in. So you feel endeavored to help others because you are thriving in this kind of a society, right? So people are kind to you, you will then exude kindness. If you are exposed to toxicity, you will then become toxic in that environment. So we aim to at least have any graduating resident be empathetic, kind, educated, well-learned, and have enthusiasm for medicine. And this is why we come to CPS, is because we want to learn, we want to help our patients. We've made multiple diagnoses because of what we've seen on CPS, rare diagnosis, rare things that we've never seen before. We learn, we take it back to our institutions, and we make these diagnoses. And ultimately, at the end of the day, we're helping people, which is really important. That is what we're here for, is to serve our community and our patients. So that's the kind of climate. The other thing is to have fun, learn and have fun. And so, I like that everybody has fun. So soccer is great. Johan is a very aggressive soccer player, so I always watch out. I move away from him because he goes for the goal. So I've been playing since 2017. I'm older now. I got to be careful. But that was a fun tournament, right, Johan? This past year, and then we just had a Thanksgiving potluck, which was great. And then I remember the Christmas party is coming around the corner, so I always bring the music. This year I'll bring karaoke. I'll bring a projection screen. So, and then Miss Caroline will bring food. So we'll have fun with that. I think Vinny was there last year as well. So he taught everybody, a bunch of the residents dancing. So it's important to have, a space where you learn, and also you have downtime, time for decompression. And also if you have a supportive GME, which invests in the residents and residents' well-being, everybody, the experience turns out to be a positive one. That's all I had to say.
Amazing. Thank you so much. This was an amazing VMR. Thank you all for the residents, and Ravi for being here, Franco for connecting and presenting this amazing case. It was an awesome session. I'm just really thankful for you all. So I hope you all have a great Saturday, and see you all on our next Saturday's 4 sessions. Bye-bye.
Bye. Thanks for coming.